awards from top doctor to AOA and endowed directorship, and your interests are in cerebrovascular disease in children and young adults. So without further ado, please begin. Oh, and just for one thing, we do see it as presenter view. I know you were talking about that earlier.
Okay, that look good? Yeah.
Yeah.
All right. Well, good morning, and thanks for having me, at least virtually. Thanks for that kind introduction. I did an adult stroke fellowship, but I tend not to see adults except maybe young adults with sort of pediatric or young stroke type issues in my clinical practice. So we'll just sort of go through. My disclosures are really that we'll talk about off-label TPA and mechanical thrombectomy in children, and I have some funding, and I write a chapter on sickle cell disease and stroke for Up to Date, so I get some royalties for that. And we'll focus on sort of epidemiology and then differential diagnosis of a kid with a acute or subacute hemiparesis, and then kind of how having a stroke protocol and team can really help, and then some of just the management issues and populations high risk for stroke at a young age, children and young adults. So there's definitely overlap. And so I will focus on childhood stroke as opposed to perinatal stroke. It's just worth knowing that perinatal stroke is, depends on which literature you read. I wrote there 1 in 4,000 live births. My friend Adam Curtin, who's at the Children's Hospital in Calgary, Canada, did a population-based look at this, and he thinks it's more like 1 in 2,000 if you kind of include everybody. So it's quite a few children. But the kids that we're really, sort of being able to intervene on right now are obviously the non-neonates. And for those, it's just a little different than adults, where there are more hemorrhagic strokes in children proportionally, right? So if you thought 13 to 15% of adults have hemorrhagic stroke, in children it's more like 40%. It's still, small numbers, but I think knowing that stroke is at least as common as brain tumor in children, I think is helpful, because when we're seeing children urgently in the emergency department and things like that, we often think of brain tumor and we may not think of stroke as easily. And so it just kind of keeps in our mind. It's a rare thing, but if you're at a tertiary children's medical center, as y'all are, you will see it. And then just to note that really the American Heart Association for a number of years now has said that all hospitals should have educational programs for healthcare providers at all levels to, have a plan for children who present with stroke-like symptoms. And that can be stabilized and transfer for a lot of hospitals, but it really, it's worthwhile to put some sort of guideline together, I think. And a lot of times you all may have nearby hospitals contact you and to understand if you can be their plan for rapid transfer, right? And so then, what are the challenges, and why speak to a larger audience that's beyond pediatric neurology about stroke care? And it's just that, the workforce of pediatric neurologists means that a lot of times neurologists will not be the first or even the second or third person to see a child with stroke. At a lot of centers, pediatric neurologists aren't in-house. I think there's nowhere that I know of that has faculty in-house at night for pediatric neurology. We have a night float system, so we do have residents in their 4th and 5th years in-house at night. But there's often a lot of phone advice going on. And the other challenges obviously are imaging, in young kids. We know that CT won't be definitive, and I'll show you some examples of that. That CTA is, challenging with radiation and dye, and that MRI is not available 24/7. So, and then you may need sedation for kids. So it's just, there's a number of things that sort of make every case, it feels like, even when you have a protocol, like, should we follow this protocol exactly, or do we need to modify it? So it's an ongoing challenge. And I think as a result, a lot of centers, adult stroke neurologists are asked to get involved in pediatric stroke triage and protocols. I've talked to a lot of adult stroke neurologists around the country that are doing that, and it's just, I think everyone does their best to take care of these kids. And so, just worth knowing that 60% of kids will have a persistent disability after a stroke, and then obviously have decades to live with those deficits. And so really, we're trying to provide care that prevents disability. And then why do kids have stroke? So the top 3 causes, I think, and may change over time, but arteriopathy is really the thing that, at least in my early training, I didn't hear that much about. Maybe I knew about dissection, but focal cerebral arteriopathy, which seems to be some sort of inflammatory, post-infectious sort of situation that really only goes for one blood vessel, was definitely something that I didn't hear much about, but turns out to be a fairly big player. Moya, I think, is increasingly recognized. And some of the post-infectious things, we don't see as much HIV-induced vasculopathy because we treat it better in children, or we treat pregnant moms, and then their kids don't develop congenital HIV and then vessel issues. We vaccinate for varicella generally, so we don't see as much post-varicella stroke, though in Europe, where they don't vaccinate for varicella, they sure see a lot of stroke in the year following the chickenpox. I think cardioembolic stroke is really what we see more of, because the more kids with severe congenital heart disease survive, the more we see complications. In contrast, sickle cell anemia, these are the numbers that 11% will have a clinical stroke by age 20 if no primary prevention. So, in the US, most kids get primary prevention, and that probably drops down your stroke rate about tenfold to about 1%. Silent infarcts, we haven't really made a big dent in, and there are definitely places, most of the world doesn't do primary prevention for sickle cell anemia. So worldwide, stroke is still a big, big deal. And then obviously there are all kinds of unusual causes of stroke. It's always humbling, actually, how even I can have done stroke for 20 years and still there'll be a case that just kind of stops me in my tracks about every other month, that I'll think that was not what I was expecting. And then hemorrhagic stroke is vascular generally. So a lot of AVMs, cav-mals, usually a couple aneurysms a year at big centers, not common, but it happens. And then lots of other, coagulation disorders, et cetera. So things to think about when you see kids with bleeds, vascular first, but then lots of other causes. And then how do kids present? Mostly they look just like adults. They have hemiparesis and aphasia, though often the aphasia is thought of as, a shy child. The one big thing is that they do seize a lot. And this is true of, children in general. Kids with stroke, about a quarter will have a seizure at stroke onset, and will often fool us, and for a few minutes at least, into thinking they have a focal seizure, which is vastly more common, that's idiopathic and not a secondary cause like a stroke. And so I'll show you some of our data, but I think when you're seeing a kid with the hemiparesis, you should sort of think in this order. Like, is this a complicated migraine with hemi? Is this a focal seizure with Todd's paralysis? Is this a stroke? Or is there other focal brain pathology? My friend Renee Schellhaus, years ago, when she was a resident at CHOP, published a paper that kind of just looked at their data, and there was a lot of other bad stuff that were stroke mimics, and that's what we find as well. And so, we'll talk a little more about that, but I think just emphasizing, when I think about what's improved outcomes for adults with stroke, it's pretty much thrombolysis and endovascular therapy, reperfusing the brain, and having a stroke center where you provide good supportive care. And I think that's probably no different in children. You can't always provide thrombolytic and endovascular therapy, and there's still safety data that we need more of. but in general, particularly providing supportive care is a lot of what we do. This is not meant to go over exhaustively, but I would just, emphasize having a stroke and a process, having a stroke process at your center that you can follow, and that everyone kind of agrees to. And I feel like this was negotiated in about 2011 at our center, and we've sort of made small adjustments since, but honestly, very few. And we'll sort of talk about that. And so for us, we activate a pediatric stroke alert or code stroke when we have a child with stroke-like symptoms in the last 48 hours. And we choose that longer time window because if you miss a stroke, large stroke, you will have cerebral edema and concerns. And we think that, we will change our management to the patient, obviously, and rather urgently. Now, maybe what we don't do is stroke alert every child who wakes up from a cardiac surgery 2 days later, and we think the stroke probably occurred at the time of cardiac surgery or something like that. But in general, we see these kids really rapidly. And there is a pediatric NIH stroke scale worth knowing, created by actually by one of my mentors, Becky Icord at CHOP. And so it's similar to the adult stroke scale, just has a few modifications so that you can use it down to about 4 months of age. And then what do we do for urgent stroke imaging? And this is very center dependent. I want to emphasize that this is not, I'm not saying everyone should do this. I'm saying that this is what we have chosen to do, but everyone needs to have a plan, right? And so our plan has been that you do an urgent non-contrast stroke protocol MRI of the brain, if at all possible. And so radiology at our center has made this protocol so that it takes less than 10 minutes. It's a diffusion, a GRE, which looks for blood, a T1 and a T2 axial, and that takes less than 10 minutes. The diffusion image takes about 30 seconds. And so if you have a really uncooperative kid, if you can get a diffusion, you can learn a lot. And so I think WashU only does the diffusion, maybe a GRE as well. And then the MRA of the head at least takes 8 minutes. So you can get these things done pretty quickly. There are still kids that can't do it. There are still times when we can't do it. We have 3 pediatric MRI scanners, but still sometimes when you're trying to put a patient in, there are 2 total spines going on under general anesthesia, and then we're short an MRI tech, and there's still not a way to do it. So I just want to say, we'd certainly default to a CT, CTA. For anyone unstable or if we can't do rapid MRI, but often we find that a rapid MRI makes a clear diagnosis and lets us know how to triage the patient. Is this a complicated migraine and they're going to go home, or is this a PICU patient? So that's where it helps us, right? If you can get it. We also know that the sensitivity of CT is lower in children, probably because we do low dose CT protocols to minimize radiation. And so we miss a lot of acute strokes. UK data that's old and Australian data found that, CT missed 47%. This is at Great Ormond Street. And in, I'm forgetting now the children's hospital, but a large children's hospital in Australia that's similar to ours with a large cardiac ICU missed 84% of ischemic strokes later seen on MRI. So, CT, if you have a large vessel occlusion, a CT angiogram will find it for you. But a CT can miss a lot of ischemia, especially if it's recent, right? And here's an example from our center, which wasn't really missed, but certainly wasn't appreciated. So this is a 2-year-old who came in after sort of an overdose of Dayquil and seemed out of it, and got this CT, which had sort of a hypodensity there. And when an MRI was obtained, we were very impressed by how large the stroke was. And so, just that this was 2:00 in the morning and there wasn't an MRI tech in-house, right? And so we got a CT, and then we knew, okay, now we really do need to get someone in here quickly and figure out what's happening. So, you can use it however you want, but rapid imaging is important. And here's another one. This is some years ago, so maybe CTs are better, but this child was, typical transfer that we all get, where a 4-year-old who sees focally, somehow with that focal seizure in an ER was transferred intubated, and so he got to our center some hours later with this head CT, and sort of billed as new onset seizure with Todd's paralysis, but this Todd's paralysis wasn't getting better, and he had a very large stroke. So you can't miss it. And this really helped us. Why? Because, but this was sort of a long time ago, before we had really good thrombectomy devices. Turned out he had a myxoma in his heart, so probably wouldn't have been retrievable with a thrombectomy device anyway. But 26 hours later, here we were, right? And so if we had done sort of the way that we used to do it when I was a resident, which is we would have gotten that CT and then we would have put him on the list for an MRI in the next day or so, we would have been in kind of bad shape, right? But we knew that this child had a big stroke and probably was going to progress to need a hemicraniectomy, and we're able to consult neurosurgery and really prepare for that. So I think, again, that's where rapid imaging helps. Okay, and then what's our data? And I will highlight Travis Ladner is now a neurosurgeon. I think he finished training just this year at the Mount Sinai program in New York, but he was a great medical student at Vanderbilt. Interested in, now he's a vascular neurosurgeon. And so we looked at our 124 patients back then and said, okay, most of them are, a large percentage are stroke, about 1 out of 4, but what else are they? And just as I said, they're, neurologic emergencies, migraines, seizures, and then a host of other things. Some, psychogenic, some Bell's palsy, things like that, you're sort of surprised or stroke alerted, but there's always an odd presentation, right? And then what were our non-stroke neurologic emergencies? A few intracranial neoplasms that seem to come on suddenly, cold meningitis, so afebrile kids who had meningitis or encephalitis, which is bad, epidural abscess, things like, just things that you're like, okay, these are sick kids. And I would say sometimes things are stroke alerted where people aren't totally sure that it's a stroke, but they're like, I'm sure I need a neurologist right now. And so, we find, I guess, looking at our data was reassuring to us that 40% of the calls that we were getting really had a neurologic emergency in our view. So it doesn't feel so bad when you're interrupting your day to go to stroke alerts, when you feel like you're having a pretty high hit rate for patients that really need you. And looking a little bit more, Megan Berry, who's now a adult and pediatric stroke neurologist at Northwestern, looked at our and sort of said, what about kids that were in the hospital at the time of stroke alerts? And it turns out, as you might expect, that the cardiac ICU is the big offender in terms of having strokes, and the pediatric ICU pretty much also, and the floor were mostly seizures in other kids. So, and then we looked at our data longer term, up for almost 400 stroke alerts over a 7-year period, and kind of split the periods in half and just looked again, like, how are we doing over time? The lighter gray bars, we're getting more calls. We're still having, maybe now it's 1 in 5 are strokes instead of 1 in 4. We are getting called for more neurologic emergencies and more seizures, but I think still worthwhile care to provide. And then, what about? I feel like the biggest question we all struggle with is, who should we give these acute interventions to? TPA, as we all know, is not approved for use in children. There was an old study, thrombolysis in pediatric stroke, or TIPS. We were the first site to have that study open in December of 2013, but kids just didn't show up in a 4.5-hour window. I don't know if they do in New York when it's a smaller landmass, but Tennessee is large. It's long and skinny. You can drive 7 hours in one direction east of here and still be in Tennessee. So kids are not showing up that fast. And so, TIPS really led to system improvements for pediatric stroke, but not use of TPA in children. I think it's not unreasonable, but I'll tell you, I've given TPA here, I think, once. It just, people don't show up quickly. It is a little different than kids. The AHA guidelines recommend that the kids be a little sicker. NIH stroke scale of 6 or more and a partial vessel occlusion seen on MRA or CTA. I think we have bent that rule a little bit a few times when we thought kids really were going to have major deficits. And then really for us, thrombectomy has been the far more, sorry, it's a little blip there, I don't know. Zoom bombing, I guess. Off-label mechanical thrombectomy, I think, has been more fruitful for us, still not common, but I think it's really worth noting that there probably is a higher risk of vessel injury, and vasospasm seems a lot more common in kids. I've seen kind of an early draft of a paper that's going to come out that's kind of going to outline that, but I think, large catheter in a relatively small vessel can cause injury. Looking at our data at our center, I think vessels are about adult size or 90% of adult size by age 5. So probably it's the under 5 crowd you should be really careful with. Here's sort of some of our thrombectomy data. We published some in that paper where we sort of outlined like 5 kids with thrombectomy, and they were way out in terms of their time for presentation, most of them, except the one kid who was in our ICU on a ventricular assist device, and so had a witness stroke in front of his nurse. But I would say we're doing 1 to 3 thrombectomies a year, whereas thrombolysis in this whole period from 2011 to 2023, we did 1, right? Here, a few kids transfer in from thrombolytics in the community hospitals, but here, and then in 2020 to 2023, we've had 3 kids given thrombolytics for stroke mimics and transferred in. So, I mean, generally that's not so bad, though we just had one kid who got TNK at an outside hospital and came altered and febrile and really needed a spinal tap, but could not get one because he'd had TNK. So, I think, you have to, really think about, and that's, again, why sometimes definitive imaging can be helpful before giving a thrombolytic, or at least understanding if you have a large vessel occlusion or partial occlusion and you really think it is a stroke and not a mimic. Now, we just did one crazy one this summer, a child who had severe congenital heart disease, hypoplastic left heart syndrome with Fontan, and we'll talk more about that, but that's probably the single highest risk group that there is, that particular really, really bad heart. And this child came 15 hours after last known well because she lives in rural Tennessee, and took a long time to come in locally, and then was transferred. And she had occlusions of her right ICA and MCA and her left MCA. Unbelievable, really. I mean, her MRA, and I'll say radiology called me and said, why doesn't she have more diffusion change with 2 large vessels blocked? We don't understand. And we didn't understand either, but she went for thrombectomy, and it definitely helped. She's still, 15 hours before she went. We don't really get good perfusion imaging in kids generally. We don't know what the norms should be. And so we kind of went with, the reason I'm showing you a flare is we went with sort of the clinical flare mismatch. This child, was hemiparetic on both sides and had, very little flare change. So we thought, even though she was 15 hours out, it was reasonable to try, especially with bilateral occlusions. And she did very well, honestly. But that's all the clot that was pulled out of her. Our interventionalist thought that her clots looked a little, quote, white to him. And she ultimately has a protein losing enteropathy, which is a complication of sometimes these hypoplastic left heart type procedures. They can develop, problems with their lymphatic system and lose proteins, and sometimes they lose anticoagulant proteins and are very clotty, which she is. But she did, despite her progression of infarct, she did, come back into clinic, walking, and following commands and signing and having a few words. So not too bad. Okay. So who should we do mechanical thrombectomy for? Again, these are the guidelines from the AHA, persistent disabling neurodeficit. So they think an NIH stroke scale of greater than equal to 6, a large artery occlusion confirmed, a larger kid. Most centers will do age 3 and up, I would say. If you have an experienced endovascular surgeon or radiologist with expertise in thrombectomy in adults and hopefully some pediatric endovascular procedures. Our interventionalist does a lot of, he delivers a lot of chemo for ocular tumors, which is a new treatment for, I'm not that new, but for retinoblastoma. And so that means in toddlers, he's up in their ophthalmic artery a lot. And so he is used to really little people. And so, I think you just want to see, do you have that sort of person, or who would be the person, and just have some sort of system or pathway so that if you don't feel comfortable or your center doesn't feel comfortable, you know who does locally. And we think that, having a system like this really, in our data, it improves the use of the pediatric NIH stroke scale. So we can have some way to track our outcomes. There's shorter door to imaging time. We are identifying candidates for intervention, and we are identifying serious stroke mimics. And other centers, I think when they weren't identifying kids with stroke, they weren't giving antiplatelet therapy as quickly. This is the Toronto group, up from 36% to 84%. They were, identifying kids with mild stroke better. And a lot of centers are, trying to think about when we can use MRI, how can we shorten the time for that? Because I do think that 17 hours was probably what we would get when we just did a CTA or CT and admitted the patient and waited for an MRI, right? I mean, if you don't have a plan for that. And, I just think in take home that, there's a lot of mimics, and migraine, focal seizure, stroke, and, 20 to 25% will have a stroke, but, you don't want to necessarily admit the 60% that aren't that sick to the ICU to watch them if you don't need to, right? And so I think having sort of a plan and a team is helpful, and hopefully prevents long-term disability. And then I think the next real frontier is to do a better job educating a lot of groups about stroke, some of these high-risk groups. And then also, like in the clinics, like we've tried here to sort of be in cardiology clinic, where it doesn't seem that anyone really wants to talk about the fact that, you can have a stroke if you have single ventricle heart disease. People don't, or any heart disease, but people don't necessarily take that educational step. The sickle cell disease clinics do a pretty good job of that. But here, we have a lot of other populations. I just listed some of them. Hereditary hemorrhagic telangiectasia, where there seems to be a founder effect in Tennessee for that. And so we have a lot of kids who have brain and lung AVMs, they have thrombosis, trisomy 21, they can have both congenital heart disease and moya-moya. NF1, if you have a large NF clinic, there's about 7% of those kids that'll have vasculopathy. And then there's just a lot of autoimmune disorders that maybe that we didn't, everyone's recognized lupus, but things like deficiency of adenosine deaminase, which is sort of a rare inflammatory condition caused by the deficiency of this enzyme. And so thinking about, how can we identify these kids quicker, and just think of it in our differential. So I'll just mention congenital heart disease and sickle cell disease primarily as kind of key examples. So congenital heart disease, the estimate now is that 1 in 150 young adults in the United States have CHD. I mean, that's like almost show-stopping to me, right? A lot of those kids don't have severe heart disease, right? They have atrial septal defects, ventricular septal defects, things like that, which are probably not that serious, but we probably find a child every other year that's had an atrial septal defect missed and has a stroke. Because they're if they're large, they don't there's not that much of a murmur. It's the small ones that make a lot of noise, usually with turbulent blood flow. And so that is an issue. And then these really high risk single ventricle congenital kids that are out there. And one of my a typical Friday afternoon text. I know you all know this. I was like doing something in my office and I got a text from a really good friend who's an adult neurologist. And he said, "What is a Fontan again?" That's what the text said. And I, of course, said, "What are you doing?" He said, "Someone with a Fontan is on their way in, with the stroke alert, and I don't know what that is anymore. I used to know, and so that's that means single ventricle heart disease, bad. And so a recent estimate was 1,300 per 100,000. So if you think about the normal rate of stroke in kids and a typical population of children is probably 3 per 100,000. And single ventricle kids just seem to clot. They clot systemically. About 30% of them will have DVT, things like that. So they seem, again, just like the patient that I showed who had thrombectomy, they will sometimes have a protein losing enteropathy or have other things that make them clot in addition to poor heart function. The surgeries that are for single ventricle are palliative, temporizing. Usually the kids have a cardiac transplant, which can be done, as young as, I think the youngest patient in my clinic that had a heart transplant at 3 months of age. Nothing went well about her surgeries. But often, they're don't have a transplant until they're in their 20s. So they will go through these stages, a Norwood, a Glenn, a Fontan, and these are all just palliative stages to get enough mixing of oxygenated and deoxygenated blood to both perfuse the body, but not flood the lungs with blood when you really only have one pumping ventricle. So, just worth thinking, what about these kids who, frankly, many of them are already here and in our sort of adult stroke units, but many more are coming, is what I will say. And, this is just sort of a compilation from a paper I wrote with a group of colleagues, and, just, cardioembolic, hemorrhagic, they seem to, have a greater risk of bleeding into the stroke. They can have watershed strokes, as well as, cardioembolic events, and often a lot of atrophy from, chronic hypoxia and multiple procedures in the, often infancy. Then they can also develop a subdural along with their stroke while you're trying to anticoagulate them, which is a lot of fun. Okay, and then lastly, kind of bopping through some of these, I think causes of young stroke that will come up. We all know what sickle cell disease is, right? In the sense that, you have a mutation and a point mutation in the beta globin gene that produces this hemoglobin S, which is poorly, leads to poorly soluble hemoglobin and polymerization when deoxygenated. So not the red cells in sickle cell disease aren't sickled all the time, but when they sickle, then they don't unsickle well, and they hemolyze and become more anemic and cause endothelial injury. And I should mention, I didn't really put that slide in, but there's sickle cell disease, which is hemoglobin S plus any other hemoglobin abnormality. It can be SC, S beta thal, lots of things. But the severe form is the homozygous SS form. And that's, at least in children, that's the worst one that we see. I think as you get older, some of the others like hemoglobin SC will, have more propensity for thrombosis and things like that. But in kids, we use elevated TCD velocity, so a nice ultrasound to pick out high-risk kids. Other high-risk kids are obviously prior, even silent infarct, kids with very low hemoglobins. Most of these kids walk around with, they're not being treated with hemoglobins of 6 or 7. So when they go into anemic crisis, it's 5. Nowadays, they often get medications that raise their hemoglobin a point or two, but again, in crisis will drop down. And I think, we, at least when I was in training and younger, I used to think that all patients with sickle cell disease that had strokes had moya or vasculopathy. It turns out it's only 10% of kids and maybe 15% of adults that really have severe intracranial stenosis. And really, I think it's getting less all the time with better care. But so the elevated TCD velocity doesn't necessarily mean intracranial stenosis. It may just mean elevated cerebral blood flow. But it's important, right? Because the risk of stroke in these kids is about 100 times the risk of other kids if you do nothing. Unfortunately, hematologists are way ahead there and have done lots of work over the last 30 years, really. But silent infarcts, we are not winning. Those are the little infarcts that are in the mostly in the border zones of cerebral blood flow, and there's no plateau. This is our Vanderbilt data in adults, and 53% of adults of an average age of 30 had silent cerebral infarcts. So, there is one study done by my mentor Michael DeBon using transfusions for silent cerebral infarcts, and it does work. It's just the number needed to treat to prevent silent infarct was about 13 people with monthly blood transfusions. So you can imagine that most patients don't really want monthly blood transfusions, and there's a lot of complications to that. So I think there's just a lot more work to do here. We know that silent cerebral infarcts predict new, or they used to be called silent strokes. I think that's probably not the best term, but they definitely predict having more. So once you've had one, you're a high risk. And then TCD, it definitely predicts stroke risk in children, but it doesn't, as I mentioned, necessarily mean intracranial stenosis. That Bernoulli effect we all learned about in high school is the diameter decreases, the velocity increases. And so, I think one of the things my research is focused on is how can we find the patients that are at risk quick, and TCD really isn't that helpful once you've had any neurologic issue. It's good as a screener, but probably elevated cerebral blood flow is a major hemodynamic risk factor for stroke in children and probably in adults too. TCD has not been validated for adults, so we're looking for other methods. And then what happens to these patients? I realize this is sort of not in the spectrum of neurology, but it's kind of a pet peeve of mine that people tell me all the time, like, oh, we're just going to cure sickle cell disease and then we won't have any problems with it anymore. And I think, the cures like stem cell transplant and gene therapy and things like that really aren't available to most of the world. And they also aren't applied early in life. And so at least the adults that I see, and kids will have a lot of complications of their sickle cell disease still, even if they do get one of these curative therapies that are really still experimental. But hydroxyurea is really the standard. It improves pain, it elevates your fetal hemoglobin and elevates your total hemoglobin. So that's helpful. For stroke prevention, we've done some studies in Africa, and there are more in progress. It does help for sure. I don't think it helps quite as much as transfusion, but if you had a stroke and you're placed on transfusion, about 50% will have another silent or overt stroke, especially those with vascular disease. So, a lot of times we think of transfusions after a stroke as palliative, though helpful. And then transplant, there not a lot of patients have a perfect match for that. And so there's a lot of work going on, at least at our center and a consortium of adult centers, for doing haplo BMTs. So like half match where you don't need a full match. There's data coming. It does seem to help. But there are toxicities to all of these things. There are new anti-sickling drugs, like voxelotor is one. And then there's gene therapy for which there have been some complications, like myeloid cancers, and there's some real promise there as well. There's also a lot of toxicity to the regimen. So the PrEP regimen for gene therapy usually causes sterility, which patients don't love. So just anyway, probably more than you want to know about sickle cell disease, but I'm pretty passionate about this population and and how we can help them. I think historically people just kind of said, oh, well, you've had a stroke, there's not much we can do, it's sickle cell disease. I think the ASH, or American Society of Hematology guidelines, are to rapidly transfuse these patients. So when you're seeing a patient in the ER, an adult even, who has stroke-like symptoms, to think about, okay, it's probably going to be pretty hard to get an exchange transfusion stat, though if you can, great. But if you can't do that within an hour or two, give a simple transfusion, to bring the hemoglobin up, especially if the hemoglobin's less than 8.5, which will be in most. You don't want to bring it up too high, because sickle red blood cells increase blood viscosity. And so you need to, bring down your percent S while you bring the hemoglobin up. And I think one thing we learned when working on these American Society of Hematology guidelines and really having patient and family stakeholders participate is that while we might think that in many of these cases, TPA doesn't make a lot of sense mechanistically, adults with sickle cell disease don't want to get less treatment, right, than other adults. So we should really still think about TPA for young adults. I'm not sure I would use off-label TPA in a kid with sickle cell disease, but in an adult, I would certainly think about it, especially if they have, adult type risk factors, and many do. And then secondary stroke prevention, there's no evidence for aspirin, but I would consider it with Moyamoya syndrome, and regular transfusions are a thing, at least until you think about more definitive treatments as well, like curative therapies. All right, we sort of talked about that. And then just to emphasize, where are the silent infarcts? They're in these border zones of cerebral blood flow. This is a paper by Andrea Ford at WashU, where she overlaid, the silent cerebral infarcts of more than 200 kids with sickle cell disease, and 90% are in this border zone of cerebral blood flow, right between the ACA, MCA, PCA territories. And then our data, we have more, but, kind of thinking about, okay, so this is a patient who gets, this is a patient who got all the things. So a pre-transfusion, his blood flow is very high, right? So the little marker over here, so very high cerebral blood flow, gets a transfusion, blood flow comes down, but not a lot, right? Gets a transplant, blood flow is almost normal, like a healthy control, and the hemoglobin goes up accordingly. And this patient actually had Moyamoya syndrome, so won't be totally normal. But if you didn't have intracranial stenosis, I think improving your cerebral hemodynamics with elevating the hemoglobin and potentially with transplant really helps. With intracranial stenosis, I still think it helps, just probably not as much, right, because of pre-existing damage. So with that, we got just a couple minutes left. I will mention, the always humbling thing that happened to me over Thanksgiving weekend. And I think this just sort of, I think when we're all thinking about stroke in the young, in this case could be on the adult hospital and the pediatric hospital, right? And so a 17-year-old came in with no significant past medical history, was Black Friday shopping with her mom at 6 o'clock in the morning, and had a sudden onset of left hemiparesis. She went to an adult hospital that was very near where she was. She had a right M1 occlusion and got TNK and thrombectomy. The stroke neurologist that was there had trained at Vanderbilt and was about a year and a half out of fellowship, and said, yep, I think this is an adult-sized person. We should do adult-sized things. She got TNK an hour and a half from symptom onset and went from a stroke scale of 14 to 1. And so then she came to us for care, and, we got, oops, that didn't work. Shoot, my animation didn't work. I'm sorry about that. The bottom line is, she didn't have a dissection. She had a normal bubble study. She had, she was anemic, well, that's a typo. Hemoglobin was 10, and platelets of 68. So we all sort of went hemoglobin of 10, platelets of 68. Okay, her SED rate's normal of 2, her CRP is 2.5, ANA, which takes a day to come back. We all sort of looking at her, and then thinking about what next, right? And so sort of big hematologic workup around the platelets, following up that ANA, and she had a slightly prolonged PTT, urine with protein in it, and antiphospholipid antibody syndrome. And so it sort of took us and a new diagnosis of lupus. And so I think, for me, this is just like a reminder that even after 20 years, stroke in the young is always interesting and can be a little bit humbling, where you sort of, I kept looking at her stuff going, what am I missing here? We obviously knew things were abnormal, but it just takes that her platelets were abnormal and stuff. But at least to me, anemia and thrombocytopenia as her and no reported other systemic symptoms didn't scream lupus until it did. So I'm happy to, talk about any cases or any challenges, and just want to sort of say thank you for the invitation, and also mention that there is an International Pediatric Stroke Organization. It has good webinars about every month with challenging cases, an in-person meeting every other year, and lots of interaction, hopefully with multidisciplinary groups. So there's pediatric neurologists, neurosurgeons, hematologists, and rehab professionals, kind of all as part of this group. So lots of ways to get involved if you're interested.
Can I go with my first question?
Sure.
Good morning, and thank you so much for a wonderful presentation. And I was happy that, you were mentioning Michael DeBon's work. I was part of the SIT trial. And coming back to your last patient, yes, you figured that this was lupus, but the treatment was quite dramatic and the improvement. So on hindsight, even if we do know it's lupus, I think it's worth doing the treatment she got. Would you say that?
I would say that, yeah. And this, I think, is the hard part for us, is that, there's not a lot of data. There's one paper actually just published, I think within the last month, that compared kids who got thrombectomy with a large vessel occlusion and kids who did not. And there's 25 patients in each group from 2 countries. But they did say, the conclusion was that those with thrombectomy did better, and I think that's not surprising, right? But it's an uncomfortable place. And what I didn't say, right, is that there's no data for TNK in children. I mean, we have no idea even what the pharmacokinetics are. But I think there's fast coming is the time when adult hospitals don't even stock TPA. So I think kids are going to be getting these treatments. And I think it was the right thing to do in this case. I think what's harder is when the patient is 5. When the patient is 17 and bigger than me, which she was, I could, I can really support that. I think the little kids are harder, and it's really a lot of shared decision making with families.
Thank you so much.
Yeah, and thanks for being a part of the SID trial. I was a resident at the time and did a lot of neurologic exams for that trial.
Are they good in here? But the people doing the flu shot, are they good?
Are you trying to
any
ask
other questions or discussion points?
Hi, Lori. Question for you. I'm being asked, you mentioned about tenecteplase and little pediatric data. Do you know any centers that have included tenecteplase into their pediatric stroke algorithm? Because I'm being asked to seriously take a look at tenecteplase, because one of the hospitals that I'm involved in is not going to be using TPA. They're going to be primarily.
Yep. I do know Kristen Gilliam's at WashU. That WashU is not going to stock TPA anymore. And I know she's given it at least once. And she and Kate LaFond, who's a pediatric neurologist at Seattle Children's, have like this little survey thing that you fill out, and I agreed to do it just because they send you a little survey every month, and they say, did you give TNK this month? And then you say yes or no. And this month I had to say, well, I didn't give TNK, but I received a kid that got TNK, and she did fine. And then a couple months ago, I had to say I received a kid that got TNK that did not have a stroke. Where it delayed their care because they couldn't get a spinal tap because they got TNK. But it's tricky, right? Our adult hospital has gone entirely to TNK, and our pediatric hospital has a separate pharmacy. And they asked if I wanted to switch, and I said, well, do you have any pharmacokinetic data in children? And that you can advise on if the dosing should be different? And they said no, and never mind, forget our question, we'll keep the TPA. So I think it's coming up, right? It's definitely going to keep coming up, and I don't have any reason to think the dose ought to be different in kids, but I don't have any data at all to say.
Thank you.
So there's a question in the chat, which is actually similar to a question I want to ask. What other factors other than age would you consider when deciding to give TPA? And this is definitely those patients that are definitely like not candidates for a thrombectomy, but kind of fall in that gray zone.
I think, if I can confirm it's a stroke, for sure, I would think about giving it, to anyone who really meets criteria, right? I would just use the adult criteria and the adult dose. And I think back to a couple of patients. There was one patient here. This always happens when I'm out of town. I was at like the Child Neurology Society meeting, and a physician's child came in with a small thalamic stroke and was within the window for TPA. And her father said, I'm a doctor and I don't want my kid to get TPA. I don't think there's enough safety data. That's a really small stroke. But she's had a lot of deficit from that really small stroke and basically has a hand that she can't use well. And so, you sort of think like I would have, and we offered TPA to that family, and with shared decision making, they didn't want it. But I think I would offer it to kids within the window. I don't know. It's always hard to know, should you extend the window on TPA more than 4.5 hours, like wake up stroke and stuff like that, like it's been done in the adult world. I might be a little uncomfortable with that. But I think those, but if you use the adult stroke criteria, I think that's what I would use. And then just making sure there's not something else odd going on, right? That you think really this is probably a metabolic stroke or something else strange. And sickle cell, I think, would be the other category where, they're known to bleed more easily. And so I think that would be if you saw no large vessel occlusion, no vasculopathy, at least I would definitely opt for transfusing first.
I have a follow-up question. I'm sorry. In the patient that you were mentioning, the physician's child who had the thalamic stroke, and again, one of my colleagues' recent review, because we always worry about who's going to have a deficit, who's not going to have, what is the role of plasticity, and so on, that it came out that, and again, in practice, since I've been doing it for a long time, that the thalamic ones are left with a deficit. So knowing that information, would we have I now said, hey, this would be a reason to push, because if thalamus was spared, then the deficit is not going to be that much. But if it's thalamic, there is going to be a deficit, and that's going to be quite limiting functionally, especially when children grow up to be adults and live a long time. Would that make us, convince us and to say, hey, let's choose a more, active role in intervention?
I think so. I think the thalamus, if you hit the internal capsule, those are going to be more severe motor deficits, for sure. I think I think that if you're offering, unless someone has a contraindication, I do think that, I mean, the TIPS trial that we were trying to do that was sort of evidence-based and, was ages 2 and up. So I think I would, it's hard, when you're talking to families about the severity of deficit. I will say that even though we say basal ganglia is bad, the thalamus is bad, there are exceptions. You're right. I mean, there is sometimes plasticity that we don't expect, but I think you have to be very honest with people and say, I would expect this stroke to cause deficits. And that's where it's hard when it says, oh, your NIH stroke scale should be 6. If your NIH stroke scale is 4 and you can't use your hand, that's a pretty disabling deficit.
Yes. That's the one thing that I took away from having reviewed it, saying, and again, having seen and wondered why is this child having more deficit than others, it was clearly the thalamus. If the MCA is involved in thalamus spread, they do much better.
Yeah, in general. Though
Yes.
again, sometimes you'll tag the internal capsule and you'll think this is a very small volume stroke to have this much deficit.
Yes.
The thalamic ones often, in my experience, will develop a dystonia later on that can be very difficult to treat. And so, I think this kid honestly looks worse a couple years later than she did at the time of her stroke because the dystonia that she developed is so tough.
But thank you again, an important point.
If you do still have time, we have 2 questions in the chat, and then I have one follow-up question. One is, what is the current outlook of performing thrombectomies with large bore for pediatric populations, especially in light of the newer adult trial showing benefits?
I think it's, I think that people are doing it. And I think we're trying, I try to never do a thrombectomy unless I'm enrolling that patient in an outcome study. So the International Pediatric Stroke Study is just a registry, but we gather data and keep outcomes. And so I'll just be honest, there's no payment for enrolling patients. It's just on your own time. And, if I see 100 kids with stroke per year, I honestly probably don't have time to enroll all of them, but the thrombectomy or intervention ones, I enroll every one. And so I think getting outcome data is important. There is actually like a new study out of Stanford where they're going to let some of us have access to the rapid software at children's hospitals where no one has paid for it. So with a research license, like to try to see, can we use some of that perfusion imaging and what should be the norms? Because right now, yeah, I think people are doing, thrombectomies, but like, we're not using perfusion imaging to guide that, right? We're just looking at the diffusion and at the flare and saying, well, there's not too much flare change, just go ahead. And then the next question I see is about mechanical thrombectomy for dissection. Yeah, that's tougher. I feel like you've already got an injured vessel and you're putting a device in it. And so I would talk with my interventionalist seriously about what does he think we can do safely. I usually, he's not super excited about putting a catheter in an already injured vessel. But would he? That one hasn't come up for us. But when we've talked about, doing procedures and things, there's occasionally kids who'll have a vert dissection that will throw a couple of clots, and we'll always have this discussion, should we do something? And nobody really wants to leave hardware in a child and stent something or do an intervention like that. So I don't know what you all would do with a dissection. Would you do a thrombectomy in an adult with a dissection?
This one is related to sickle cell, at least in the pediatric department, since we have such a large immigrant population from the Caribbean and also West Africa, we get pretty comfortable in that, at least on the heme side of things. One of the patients we had last year had come in with altered mental status. He's 5, so he wouldn't count as much, but in a slightly older patient who had what he had, which was a relatively recent, I guess, silent infarct, maybe not silent in this case. Would you consider any treatments? Because we know right now, obviously, that is controversial for any acute or secondary, mostly acute treatment for silent infarcts.
You're saying would I give an acute treatment for a silent infarct?
Because he had come in with altered mental status. We
Yeah.
couldn't really figure out a different cause for his symptoms.
I mean, I think so, you know, I do MRI research, right? And we scan over 200 kids and adults with sickle cell disease, you know, and yeah, every once in a while we find an acute silent infarct, right? So the diffusion will light up with a little dot on it. Yeah, and I would usually recommend that those patients get a transfusion. I mean, we know that they that those things are probably happening all the time at home and we don't see them. But I think if you have a child that you're like, okay, well, they're actively having silent infarcts now, then their cerebral hemodynamics are not where they need to be, right? They're not getting enough oxygen and blood flow to the brain. And so I would do what I could to intervene on that with a transfusion. And then we would talk to the family about, you know, would you want to implement the SID trial protocol where you got monthly transfusions? And some families say no, they don't want that. And then I think the next frontier for those kids will be, you know, can you do something more than hydroxyurea for those kids? You know, hydroxyurea plus another oral agent. To be honest, I think that's for most of the world, that's what's going to help, right? Most people can't get blood every month indefinitely, and hydroxyurea has helped, I think, but it's probably not the only answer. But so yes, so the answer, yes, I would do something if I saw an acute, even a tiny infarct, right? I would try to bring up the hemoglobin, bring down the %S, and really be nice to the brain.
And my last question is, in a child presenting with seizures and possible TODs, what would like tip you over in terms of considering this to be more than, you know, just seizure and TODs?
First, risk factors, right? So if you see a kid, I mean, it's always a red flag when there's a kid with congenital heart disease with a new seizure onset and weakness afterwards. So, I mean, or sickle cell disease, the same thing. I consider a seizure in a kid with sickle cell disease to be stroke till proven otherwise, though they can have febrile seizures like everybody else, or, you know, epilepsy like everybody else. That happens. I think there's like one kid in my clinic with sickle cell and absence and GTC epilepsy that's just not related. And so risk factors for sure. And then I think just duration. So what we've kind of said is, okay, a kid who has TODS paralysis, are we going to scan every one of those? I mean, there's 4 of those in our ER every day, probably. So what we will usually do is examine them. If there's no risk factors, are they getting better? You know, and is there something like, you know, a kid with developmental delays and autism and stuff like that, where you're like, oh, I think this is probably just a new presentation of epilepsy. But if the kid is not getting better, we might, you know, see them and examine again in 30 minutes and examine again in 30 minutes, which you hate waiting. If it's a stroke, you're just killing an hour there. But if it feels like this is probably just a seizure, I think it's reasonable to delay a little bit. But that's the least comfortable thing that we all do, I think, right? And I think that's why we get so many stroke alerts from the ER on kids with focal seizures, is because they feel the same as us. You know, it's not comfortable. But happily, most of the time, by the time we get down there to examine them, they're getting better and are like sitting up, like asking for juice or something. The ones that are not getting better, we scan them. You know, that's why you have a short MRI protocol that's 10 minutes long, is we can do that really quick. And if someone doesn't have any ischemia or any blood and you really don't think it's a TIA, then I don't go ahead with the vascular imaging. I just do 10 minutes and get it done. 10-minute MRI. All right. Well, I know it's late, getting late there. From you guys probably have stuff to get onto this morning, but gosh, it's fun to talk and share cases and think about how I see Dr. Levine's comment that he would do a thrombectomy in someone with a dissection. So now I need to go back to my interventionalist and have an additional discussion, because he will probably agree with Dr. Levine. My interventionalist here is an adult stroke neurologist who's also trained in intervention, so he'll probably say, "What are you thinking?" Which it's good to have friends like that you can have these conversations with.
Mhm.
So, and I see another comment and support too. So.